more low cost.
No, you want to work with that crew
That our electrician just our electrician.
It's my pleasure to be able to introduce our speaker today. And this is the second in the series of talks that the Pender Island Healthcare Society has organized called Cheers to Your Good Health. And as part of the Sunday at the Library series, where we're working in conjunction with the library. And so today Greg is going to talk about everything you need to know about diabetes. So Greg Bondy, our speaker, is a professor at UBC. He's located at St. Paul's Hospital in the Diabetes Treatment and Teaching Center. He trained as an endocrinologist at University of Toronto and then at Western University. And he got his first job at McGill at the Royal Victoria Hospital, where I trained. And then he came to St. Paul's Hospital 33 years ago, and he's been there ever since. And endocrinologists take care of the endocrine glands. You remember those? Those are the ones that don't have a duct. So the pancreas, the thyroid, the adrenals, and the pituitary gland. And but Greg has focused on the pancreas, which produces insulin, and he's going to tell us everything we need to know about diabetes. Yeah, Greg and his wife Sylvia, also physician, are Pender Islanders. They have a place up on Houston Road there, and they're slowly transitioning to Pender. We're hoping it'll be faster.
Well, thank you, Peter, for those kind words, and thank you for the organizers inviting me here. As Peter alluded to, I spent a lot of my time treating diabetes, and hopefully I can share with you some of my practical experiences. So the next slide basically shows the outline of the talk. It's going to tell you how you make the diagnosis of type 2 diabetes. The symptoms will be one slide, very short, and then we're going to spend some time on why it's important to know about diabetes. It really increases your risk of heart disease and kidney disease. And with that in mind, I'm going to tell you how you can prevent some of those complications. So the next slide gets right into it. This is how you make the diagnosis of diabetes. So it's a biochemical problem. And basically, you can make the diagnosis based on two different criteria. You can do a fasting glucose level, and if it's greater than 7 and you've done it twice, you got diabetes. The other way is to do what's called a hemoglobin A1C. I'm going to talk more about that in a minute. That's a test that basically measures your blood sugar level over the last 3 months. So if your A1C's over 6.5, you got diabetes. Now, you can also do an oral glucose challenge test. Anybody in the audience ever had one of those done? It's a very miserable test. I never order it, by the way. You have to drink a drink that's sickly sweet. You then have to stick around for 2 hours. And then we measure your sugar. And if your sugar after 2 hours is greater than 11.1, you got diabetes. But 99.9% of the time, you can do it with either an A1C or a fasting glucose. Okay? So let's just focus on the A1C. Next slide. That really measures your blood sugar over the last 3 months. And the reason I want to spend time on it is this is what we focus in on when we treat diabetes. For most adults, we like to keep the A1C around 7% or under. If we keep it under 7%, we dramatically reduce any complications related to diabetes. That being said, it's a very simple assay. What you do is you take red blood cells from the blood. Now, you may or may not know this, but red blood cells generally live about 3 months. So we take the red blood cells and then we extract a protein called hemoglobin. And then we simply measure the amount of glucose that's attached to the hemoglobin. So you can see if your sugars have been high over the last 3 months, you'll have a higher percentage of glucose attached to that protein. Conversely, if your sugars have been really good, your A1C will be in the appropriate range. So it's really, your fasting glucose can bounce around. It can bounce around based on your activity level. It can bounce around what you ate the night before. The A1C is a much more stable measurement. And when I treat a diabetic, 99.9% of the time, that's what I'm trying to accomplish from a goal standpoint. Now, the only time you can't use an A1C is in people whose red blood cells don't live 3 months. And the classic example of that is anybody who has kidney disease. So in people with kidney disease, their red blood cells don't live 3 months. If you measure the A1C, it will give you the false sense that the A1C, it'll be lower, so you give the false sense that the sugars are actually good. Okay, so A1C, if you got diabetes, you got to know what that means. Next slide. So what are the symptoms of diabetes? And I'm talking about type 2 diabetes, by the way. Okay? There's 2 kinds of diabetes. Type 1 is the people, usually in kids, who are absolutely deficient in insulin. If they don't get insulin, they die. I'm talking about type 2 diabetes. That's 90+% of all people with diabetes have type 2 diabetes. When you got type 2 diabetes, most people don't have any symptoms at all. It's picked up on a blood test. Okay? Now, if you do come in and you're insulin deficient, you're going to have signs of insulin deficiency. And that's usually people who come in and they've lost 20, 30 pounds. They're really thirsty. They're peeing every hour. So those are the people who are significantly insulin deficient. Usually I have to put them on insulin. Once I get their sugars down, often we can get them off insulin. Okay? Now, in people with regular type 2 diabetes with no symptoms, if you question them closely, a lot of them will tell you that they have developed numbness in their feet. So that's a sign of peripheral neuropathy. When your sugars are high, your nerves are not happy. And one of the first things that happens is you start getting numbness. And you usually feel that in your feet or in the tips of your fingers. Now the other thing, I work at the Heart Center at St. Paul's, so my focus is vascular disease. A lot of people with diabetes often present with heart attacks. As I'm going to show you, 85% of diabetics will have a vascular event. So often when people first present with a heart attack, when they do their initial blood work, they're found to be diabetic. Okay? And you should always, that's the first thing as a clinician, you always want to know about, is there any history of cardiovascular disease? You also want to know, is there any history of a polyneuropathy, meaning nerves, are they being affected? Next slide. So, in terms of diabetes itself, this is a build-up slide, if you could, it is a very important problem. As you can see, it's quite sobering when you look at the statistics, and this data is getting old, but basically 1 in 11 adults in the world will have diabetes. And as you can see, when you look at the numbers, in 2017, that was 425 million people. Now, the other thing that's very, very interesting is most of this diabetes burden is occurring in low to middle income countries. Now, any ideas which countries had the biggest pickup of diabetes in the world? India. So India has, and it's very interesting, in India it's been mainly the middle class. It's a function of affluency. Okay? The Chinese, in 1960 there used to be virtually no diabetes in mainland China. Guess what? Now they got tons of diabetes. And again, it's a function of affluency, it's decreased physical activity, too many calories. Okay? Next slide. So what about Canada? This slide will show you again, 1 in 10 deaths in Canada can be linked to diabetes. Basically, your risk, when you got diabetes, I'm going to show you a slide, but 85% of diabetics will either get a stroke or a heart attack. So it's a really big component. Now I work at St. Paul's. We have a heart failure clinic there. Well over 70% of individuals in the heart failure clinic are diabetics. If you go up the floor up to the renal dialysis unit, 60% of the people in the dialysis unit are type 2 diabetics. So it's a really big component of those two comorbidities. And again, kidney disease is very much linked to having diabetes. Next slide. And this slide I bring up used to be, once I said, okay, you're a diabetic, that automatically knocked off 6 years of your life. And if you've had diabetes and heart disease, it knocks off 12 years of your life. Now, this is based on old data. I can tell you with the newer treatments for diabetes, and I'm going to tell you more about that, we can dramatically change this profile. And I can tell you that if we get your diabetes on target and treat all the appropriate things like cholesterol and blood pressure, we can virtually make your risk of getting heart disease the same as a non-diabetic. Okay? So I don't want to be too pessimistic on that case. The important case is actually make the diagnosis and then to treat individuals to appropriate targets. Now it's very interesting. We can identify problems, but I always like this story, and forgive me if you've heard this before, but the British actually discovered the cure for scurvy. Do you know how many years it took before they could actually eradicate scurvy? It took 150 years. So it tells you, you could have the knowledge of how to treat a disease, but then the system itself has to adapt so that you can actually treat things. I can tell you, diabetes is still stuck in the mind frame that, you know, there's not much you can do about it. It's because people eat too much, they don't exercise enough. I want to change that. I really, with the newer treatments for diabetes, we can dramatically change this outcome. But if you don't change things, this is what you're facing. Next slide. Another build-up slide. This is again an old slide. This is showing obviously Canada here, and it's showing you obesity trends across Canada based on different provinces. Next slide.
Oh, there you go.
There we go. So I'm not sure if you can appreciate this, but basically BC and Quebec have one of the lower levels. And people argue, well, in BC we exercise more. And in Quebec, they smoke more, so they don't get as overweight. Now, I always find it interesting when you look at this slide, you can see greater than 20%. There's the Maritimes, there are Northwest Territories. It's not showing up on the slide, but Saskatchewan's always part of this as well.
Sorry.
So now, has anybody been to Saskatchewan in the near... Well, I always find it interesting. I've given a number of talks in Saskatchewan. And again, they always treat me very well there, etc. But they're really big fans of buffets. And during the cold winter, they spend a lot of time indoors. They don't do as much exercise. And gaining weight is a real issue.
Do you show that slide in Saskatchewan?
Of course. They realize that. Actually, it's interesting because Saskatchewan's there and then Newfoundland and the Maritimes.
How much has to do with Aboriginal people?
That's a very important question because cities like Prince Albert, 30% of that city is like Aboriginal. So they do have a significant, you're absolutely correct. Now it's very interesting. I do a lot of First Nations health in BC. I go to Bella Bella. I'm going to be going to Bella Coola. It's always amazing when I go to places like that, half the town is diabetic. So there's very important ethnic, now it's very interesting, you know, in Vancouver we have very interesting different ethnic backgrounds that are at risk for diabetes. We mentioned First Nations. Can you think of any other ethnic group that would be risk for diabetes?
South specific island?
Yeah, Fijians. Yeah, so Fijians are many of the Sikh community. So in the Punjab, they're working on the farms, they come here, they don't do much physical activity, their rates for diabetes and heart disease go way up.
So are all those ethnic risks due to body weight, or are there other genetic things?
There is probably a combination of environmental and genetics. So in terms of Fijians, these are people originally from India who settled in Fiji, and they obviously brought a bad gene with them. And then if they gain weight or are inactive, then that gene's allowed to express itself. Okay, so again, obesity, as I'm going to show you, is a big driver of diabetes. Next slide.
Sorry, it keeps changing.
All right, just keep through it. The reason I put this slide, I apologize how complicated it is, but basically it's showing that glycemic parameters or control, before you get type 2 diabetes, your risk for getting heart disease goes up. So people in the pre-diabetic phase, where you're starting to show signs that you're on the road to getting diabetes, like your morning sugar is a bit elevated, when you plot these individuals, you will see that their risk for getting heart disease goes up even before they get frank diabetes. Okay? And also this tends to show you why diabetes is a progressive condition, meaning as time goes on, things get worse. And again, using some of the more modern treatments of diabetes, we can often prevent this inevitable climb or progression of diabetes. Next slide. So, what are the complications? Well, I alluded to some earlier. Macrovascular complications are things like a heart attack, stroke, and peripheral artery disease. Microvascular is generally your kidneys, your peripheral nerves, and then your eyes. Okay? And heart failure, I'm going to tell you more about it, but as I told you earlier, at the heart failure clinic at St. Paul's, 60-70% of those individuals are type 2 diabetics. So heart failure is a really big component of type 2 diabetics. Now, as I alluded to, it's not all doom and gloom. If you lower A1C 1%, you can reduce deaths related to diabetes by 21%. You can almost reduce microvascular by 40%. You can reduce heart attacks, you can reduce stroke. So if you get your sugars on track, you can really prevent many of these comorbidities that diabetics are prone to getting. Okay, so next slide. So again, I know I keep hammering the point here, but 85% of individuals with diabetes will get a stroke or a heart attack. Okay? And it's linked directly to your A1C. As your A1C goes up, there's a linear relationship between your risk of getting a vascular event.
What does A1C stand for?
That was actually the third slide that I showed you, but it stands for hemoglobin A1C. So again, it's the amount of sugar that's attached to hemoglobin. That's what hemoglobin A1C means.
Yeah, what the A1 stays for? Hemoglobin A1C. What is the A1?
That's a very good question. I've never had that asked.
Look it up. I'm sure Google will tell you. Don't worry.
Okay. Next slide. You threw me on that one.
We don't know what A1C is.
Okay, so again, the feature of diabetes is multi-vessel vascular occurrence. So basically, in people with diabetes, you can see they're very prone to getting multiple vascular events, meaning stroke, heart attack, peripheral vascular disease. If you look at the arteries of a person with diabetes, inevitably all the arteries in the body are being affected. Whereas in people without diabetes, often, you know, if you looked in the heart, there might be one artery that's plugged, but the others are fine. Now that's one of the reasons why diabetics generally don't do as well when you do angioplasty, where you put, you know, a tube into the artery, you then dilate it and put a stent in. The problem with diabetics is you're going to end up doing multiple vessels. You have to put in 4, 6, 8 stents. So people with diabetes generally are much better candidates for coronary bypass surgery. So the current practice is, as soon as you're diabetic, you got multivessel disease, that's what you go for. Next slide. Now, the other problem with diabetics is when they do have a heart attack, that's with STEMI and non-STEMI, this just means people who present with acute coronary syndrome, they don't do as well as people without diabetes. So they tend to die at a higher rate. Okay? Next. It is gloomy. So basically, you don't use having a first heart attack as your screening tool. Okay? Because inevitably, and that's actually true of all, even without people without diabetes, used to be 50% of your first heart attack was your last heart attack. You didn't survive it. Okay, that's why I believe a lot in preventative medicine is you don't wait for the first heart attack to screen people. You have to prevent that first event. Next slide. So let's go briefly into why diabetics have increased vascular disease. Well, one of the main features of type 2 diabetes is they have insulin resistance. And as the name implies, you make plenty of insulin, but it doesn't work well. That's usually related to the size of your body, especially abdominal fat. So obesity itself is a risk factor. Fat cells make all kinds of hormones and growth factors that increase your risk of getting heart disease. With that in mind, if you looked at markers of inflammation, and there's a variety of these we can measure in the blood. There's one called CRP. There's a whole list of these different markers. But if you looked at diabetics, inevitably those markers are elevated. And it's part of having diabetes. You just have increased inflammation. There's probably 20 different factors that sets you up for hardening of the arteries. The problem is I can't tell you what those 20 factors are. We can know some of them, and that's one of the mysteries of treating heart disease is trying to identify what those various factors are. Now, glycemic control is one of them, because diabetics, as I've alluded to, are really at risk for heart disease. Next slide. Okay, now heart failure is something that you probably haven't heard much about. Now, heart failure is really important in diabetics. It's the commonest cause of the reason why you have to go to hospital. That occurs in both men and women, and basically it's a very important component of what makes diabetics have to stay in hospital. Next slide.
But it's coming down over time, is that what it shows?
It is, but that's due to improvements in treatment.
Sorry,
It's okay, it's okay.
what I'm supposed to go.
The next slide. And again, this just shows graphically, I told you that heart attacks is a very important risk factor for diabetics, so is stroke, but as you can see, they're dwarfed by heart failure. And that's a really big factor. And some of the newer treatments for diabetics have dramatically reduced heart failure. Okay?
So the heart failure occurs
What's
throughout.
the difference between heart failure and heart attack?
Oh, okay, that's a very good question. So a heart attack basically means there's a portion of your heart that is not receiving enough blood flow. And you'll actually damage the heart itself.
You have chest pain.
Yeah, you'll have chest pain. Actually, in women, often they don't have chest pain. They'll have shortness of breath. But a heart attack is characterized by acute ischemia, meaning lack of flow to a part of the heart. you'll actually see markers of damage to the heart itself. One of the muscle proteins that we look at is troponin. Troponin is unique to cardiac muscle. It'll be released in the blood. Heart failure is basically the pump itself is failing. It's not due to damage, acute damage, but the heart itself is unable to keep up with the demands of the body. Now it's very interesting. We used to always say, well, heart failure is characterized by shortness of breath, peripheral edema, meaning fluid in your legs. But basically, it can be hard to determine heart failure clinically using conventional tools like a stethoscope or symptoms. The gold standard for heart failure is actually doing things like a cardiac echo that looks at the actual function of the heart when it beats. And then there's a blood test called BNP. That's a hormone that's released by the heart when it's failing. So those are very definitive ways of determining heart failure. Okay, but they are very important. Now the commonest cause of heart failure is actually ischemic heart disease. So hardening of the arteries to the muscle simply can't perform the way it should. Is that clear?
Yeah.
Very good. Next slide. So again, just to focus on that, diabetes affects the pump, which is the heart. Diabetes affects the arteries. If you looked at arteries of the heart, you're going to see hardening of the arteries and development of blockages and plaque. And that's what contributes to MACE. Simply is a combined endpoint, usually a heart attack or a stroke, and then heart failure. Next slide. But I've alluded to this earlier, diabetes is a really big cause of renal disease. Again, like I told you, people in the renal dialysis unit, certainly at St. Paul's, 70% of them are type 2 diabetics. And again, it's a very important source of morbidity and costs to society. Okay, it's very expensive to dialyze people, to give them renal transplants. And again, that's a really big component. And like I'm going to tell you, we can dramatically reduce renal disease with some of the newer drugs. Next slide. This is my final one on pathophysiology. So again, when you take a diabetic, you got to think about the pump, which is the heart. You got to think about the filter, which is the kidney. You got to think about the plumbing, which is your blood vessels. And they all contribute to these components that diabetics are at risk. Next slide. So, whenever I make the diagnosis of diabetes, I always sit the patient down and I tell them, this is why you have diabetes. One, you've developed insulin resistance. And again, as the name implies, you make plenty of insulin, but it doesn't work well. That's part of the whole reason you get diabetes. You keep producing tons of insulin, but it doesn't work well.
The pancreas.
Well, your pancreas is making insulin. Now, 90% of people who are overweight, so again, insulin resistance is a function of your body weight, okay, as a general rule. So as you get bigger and bigger, insulin resistance gets worse. But 90% of people who are overweight don't get diabetes. The people who get diabetes have a second hit, a second problem. The cells that make insulin have been depleted. And the next slide shows when you make the diagnosis of type 2 diabetes, you've already lost 50% of the cells that make insulin. And it's a one-way trip. They never come back. Okay? So that's one of the issues about diabetes, is it's a very progressive condition. Now, what do you think beta cells, the ones that make insulin, what do they not like? I'm sorry?
Sugar.
Well, it's interesting. If your sugars are high, you're actually correct. If your sugars are really high, you burn through your beta cells quicker. So it's very important to get your sugars down. If you get your sugars down, your beta cells are going to be much happier. Now, can you think of another way to ease the burden on the beta cells?
Exercise.
Well, that'll help, but what's the primary driver?
Weight loss.
Weight loss. Okay, so if you lose weight, beta cells, if you lose 30, 40 pounds, obviously the cells don't have to make as much insulin. Now, exercise is an important component of helping people lose weight. It won't necessarily correct. A lot of people, when they get diabetes, often they're thin, they try to outrun it, they can't outrun it. Okay? Next slide, please. Can you prevent diabetes? You can, actually. There was a very nice trial that came out about 25 years ago. Oops, go back. So the diabetes prevention trial basically took people who were pre-diabetic, so their sugars were slightly high, and basically they were enrolled, half the group, they just kept going the way they were, and the other half were given dietary counseling and exercise. So they had to go to the gym 4 times a week. If they didn't go to the gym, the study coordinator actually sent a cab to your house, picked you up, and made sure that you got to the gym. So in those individuals, after roughly 4 years, they lost on the order of around 8 pounds. Most of these people were over 200 pounds, by the way. So they lost a modest amount of weight. But just losing that modest amount of weight, they could reduce the chances of developing diabetes by close to 60%. So you don't have to do dramatic reductions to reduce the chances of getting diabetes. Next slide. With this in mind, what are risk factors that would say to you or your healthcare providers that are putting you at risk for getting diabetes? Well, this shows an individual with a big gut, and you can look at biochemical markers. So when you look at various biochemical markers in the blood, if you find your triglycerides, triglyceride is a fat that's in the blood that tends to go up as your gut goes out. If you have a low HDL, HDL is the good cholesterol. If your HDL is under 1, your risk for getting diabetes goes up dramatically. If you looked at inflammatory markers, you would find this. Basically, your sugars will be elevated in the morning, and if you measured it, we can't conveniently measure insulin resistance outside of the lab, but if we measured it in a laboratory setting, you would find most of these people have insulin resistance. Now, the only reason to make this diagnosis is it really tells you that this person is on the road to getting diabetes. So it's a very convenient tool to try to identify out of all those overweight people, which ones are at risk for getting diabetes. Next slide. And again, this is the definition of prediabetes. If your sugar in the morning is between 6.1 and 6.9, or if you do a glucose challenge, or if your A1C is between 6 and 6.4, you're pre-diabetic. That's a warning sign that you're on the road to getting diabetes. Next slide. Now, can you reverse diabetes? Any thoughts of that?
Slow it down.
What's that?
I think you could definitely slow it down.
You can slow it down, but you basically, again, if you remove insulin resistance, often you can correct diabetes. So I've had people develop full-blown diabetes, they lose 30, 40 pounds, their sugar is absolutely normalized.
Without treatment now?
They have to lose the weight.
Oh, but not
Okay.
diabetes.
But it's basically, it's how you accomplish that. Okay? So, because people always ask me, well, can I reverse my diabetes? And I said, well, you can, but the problem is, as I told you, there's 2 components to a diabetic. 1, they have insulin resistance, but 2, they've lost half their beta cells, and they're gone forever. So if you lose the weight, you could reverse it, but if you gain the weight again, you're going to get diabetes again. Okay? So when I talk about diabetes reversal, it always makes me think about my next slide, which is a Huli witch doctor. So I like practicing witchcraft. So basically, anybody ever been to Papua New Guinea? Oh, these are super cool people who live in the highlands of Papua New Guinea. This is a Huli medicine man, and basically he is the person you go to for all kinds of things. But now, by the way, I asked them, they ever heard of diabetes, and it was virtually unheard of. Okay, their main problem is being killed by poison spears and other things, but basically they don't get metabolic issues. Okay, next slide. So let's look at the management of diabetes. I'll finish off by looking at that. Next slide. A lot of people say, well, when do you start measuring blood sugars? Well, the vast majority of my patients, there's really no need to measure the blood glucose levels using either fingertip glucose measurements. Now, have anybody seen those sensors that people wear? So people who are on insulin, that's really made life a lot easier for them. So you slap this sensor either on your belly or on your arm, you take your phone, and you can measure your sugar every minute. And you can measure it while people sleep. So when you do that, it can really help with insulin adjustments for insulin-dependent diabetics. But in the vast majority of diabetics that I manage, they're on drugs that don't give you low sugars. There's no real adjustments. They don't really need to measure their glucose levels. Now, I often will prescribe glucose sensors to people to see if it'll help with their diet. Because you're going to find certain foods make your sugars go really, really high, and other foods are very friendly from a glycemic standpoint. And the only way to find out is to do the experiment. Okay? Next slide. So, again, we'll work. Basically, I'm going to talk about lowering A1C, but blood pressure management is very important. Cholesterol management is very important. And basically, we're going to talk more about those other lifestyle measures. But when you got a diabetic, because they're at risk for heart disease, you really want to make sure their blood pressure is good, their cholesterol is good, and we want to get their sugars on target. Next slide. So what about diet? Okay, now don't ask me if this is a good or a bad diet, because it keeps changing. This slide was made 50 years ago, and this was supposed to represent a high-fat diet.
Bacon and egg.
It is.
Where's the fried bread?
Basically, this is what that is with the butter, okay? So actually, things have changed. What is the biggest enemy to diabetics? Simple carbs. Okay? Carbs to a diabetic's like giving them a cigarette. So you got to really watch your intake of simple carbs. Now, fat is important. You really should reduce saturated fat. Now, a lot of people like using the keto diet. And if you're on a true keto diet, you're eating a ton of saturated fat in the hope of inducing ketosis, which takes away your appetite. But the problem is keto diets, if you look at it, they actually raise heart disease. They've never done the trial, but if you look at epidemiological evidence, it tends to make your lipids, your cholesterol worse, and tends to increase your risk of heart disease. Now, nobody can do dietary trials for heart disease because it's very hard. It's very hard to do a placebo in a diet trial. Okay, everybody knows. Now, can you name me, there's only one diet that's ever been shown to reduce heart disease. Any idea which one that is?
Mediterranean?
Absolutely correct. So the Mediterranean diet, which includes a lot of fish, very little red meat, lots of fruits and vegetables, is a very good approach. That's the diet I usually recommend that people follow. Next slide. What about exercise? Again, this is some guidelines. From a metabolic standpoint, what I tell people is do a 30-minute walk a day. You don't have to be an Olympian to get your sugars down. Metabolically, if you just do a modest amount of exercise, it improves insulin action and improves your glucose control. If you want to make your heart stronger, you got to do more vigorous exercise. But from a metabolic standpoint, just doing a 30-minute walk a day is going to do the trick. Next slide. If they smoke as a diabetic, that's a really bad combination. Now, fortunately, I don't see as many smokers. And I always like showing this slide because this is what you end up if you smoke a long time, what you look like. And this, any clever people, anybody recognize this guy? It's a wolf eel. Very good. Where do you find wolf eels? Well, you find them in the ocean around here. This one actually was photographed near Alert Bay. And wolf eels are super cool creatures. They spend all their time in little caves. They're very homely looking. But if you offer them a sea urchin, they will come out and grab it. And I always like wolf eels in native culture. If they caught a wolf eel, who was the only person in the village who could eat that thing? The medicine man. Okay, there's supposed to be some special properties. Next slide. I've hopelessly sidetracked this here, but
There was no relevance to that?
there wasn't. It was just completely at random. Okay, A1C targets. Most people, you want to get the 7%. If you can get it under 6.5, that's good, but I don't do it at the risk of getting low blood sugars. I won't put someone on insulin to get their A1C to that level. There's really not that much of a benefit. Conversely, if you're frail and elderly, an A1C of 8.5 is perfectly acceptable. Next slide. And again, if you have high A1Cs, you tend to have a lot of symptoms. You pee every hour, etc., etc. Next slide. So, I'm going to finish off just looking at the medications used to treat type 2 diabetes. This is a build-up trial. We have multiple ways to treat diabetes. As you can see, here's muscle and liver. They're important players. Who's heard of metformin? Okay, it's a very common drug. Metformin mainly works on insulin action in the liver. Okay? Then you look at the pancreas. There's a number of medications that work on the pancreas. I'm going to tell you about an SU, which is an example of what would be glyburide. That basically tells your pancreas release insulin. I'm going to tell you about GLPs. That's a drug called Ozempic that's in the news a lot. And obviously you can give insulin. Next slide. One of the newer medications is one that works on the kidney. That's called SGLT2 inhibitors. That's a transporter in your kidney that regulates sugar. Now it turns out diabetics, their kidneys retain too much sugar. That's part of the problem. And what these drugs do is they basically make you pee out sugar. And by making you pee out sugar, it lowers your sugars. And you're going to see there's important advantages of doing that. You can take something that affects the sugar uptake in the gut, but we never use those drugs anymore. So that's the basic broad outline. Now, metformin, we always use it up front. It's got a very good safety record. It's been around since the 1950s. It doesn't make you gain weight. It doesn't cause low sugars. The only issue with it is it's probably, of all the drugs I use, it probably has the most side effects. About 30% of people who go on metformin will complain of stomach upset and diarrhea. Okay? The other problem with metformin is it's not ever been shown to really dramatically reduce heart disease. And that's your focus when you treat diabetes. You want to reduce heart disease. Again, metformin's interesting. They're using it as an anti-aging drug. Have you heard about that? So certainly if you're a rat, you live longer when you go on metformin. But they've yet to show that in people. And it's going to be a very hard trial to do because you'd have to take 50,000 plus people. You'd have to follow them for almost 20 years and then find out, do you indeed extend life that way?
You're not taking metformin?
No. So metformin is a very interesting medication that way, but we use it in combination with other medications generally. Next slide. The other one is sulfonylureas. Examples of that are glyburide or glycoside, also known as diamicron. As I alluded to, it's a pill you take, and what it does is it tells your pancreas release insulin.
Isn't that going to just deplete your beta cells more?
That is true. So that's one of the features of sulfonylureas is they tend to have they're not as durable as other classes of medications. But the main problem with sulfonylureas are, just think of it, you take the pill and it releases insulin. What happens if you don't eat? You're going to get a low sugar. What happens if you decide on that day, I'm going to start being an Olympian, I'm going to go run? You'll get a low sugar. So sulfonylureas are not my favorite drug to use. Now, unfortunately, in this province, until recently, we always had to use this as a second drug. Because how much do you think sulfonylureas cost? 2 cents a day. Okay, so they're cheap, they're relatively effective, but the problem is they give you lows, they make you gain weight, and if anything, they increase your rate of dying from a heart attack. I still use them as third or fourth line. Next slide. Insulin, again, is your gold standard. It's tried and true, but the problem is it makes you gain weight, and it's always risk of hypoglycemia. So if you're truly insulin deficient, like you've lost a lot of weight, you're peeing every hour, you go on insulin. But in most type 2 diabetics, I use this as third or fourth line. Next slide. So, what about GLP agonists? You see this on TV all the time. Ozempic. And I always love this. Ask your doctor about Ozempic. I wish I had $1 for every time someone asked me that. Now, I've been using this class of medication for the last 15 years or so. So I have a lot of experience with it. It has a lot of advantages. There's a number of disadvantages as well. So how do they work? Next slide. Well, basically when you eat food, your upper intestine, it shows your colon here, but basically your upper intestine will secrete a hormone. That's a polypeptide, a protein. And that's called glucagon-like peptide. So it's a hormone that basically goes in your blood and it lasts about 3 minutes. And then it goes to your pancreas and it tells your pancreas, release insulin. And the other thing it does is it tells, there's cells that make glucagon that tends to raise your sugar. This tells, don't release glucagon anymore. So GLP is a very important controller of that whole axis. Now, people with diabetes don't make enough GLP. That's part of their problem. Now, about almost 20 years ago, they were able to make GLP synthetically. And that's what Ozempic is. It's been engineered so that, unlike natural GLP that only lasts 3 minutes, this modified polypeptide will last 7 to 10 days in your blood. So that's why Ozempic, you only need to take a shot once a week. And it's a little sub-Q injection. It doesn't hurt. Famous last word from doctors, they always say it doesn't hurt, but trust me, it doesn't hurt. Next slide. Now these are all the players currently. We don't use these. Liraglutide or Victoza is a once a dayer. It's largely been supplanted by Ozempic because it's once a week. There's actually an oral form of GLPs. It's called Rybulsus. It's effective, but you got to take it every day. You can't eat for 12 hours. Once you take the pill, you can't eat for another 45 minutes. So it's a bit complicated to take. I generally always recommend the shot of Ozempic. There's another one called Trulicity. That's an auto-injector. Again, it's not as effective as Ozempic. So that's the players. Next slide. So it's a very effective medication to lower your A1C. In fact, it's just as effective as insulin to lower your sugars. And the benefit of it is it lowers your sugars. It does not cause low sugars. It's impossible to cause a low sugar. And not only is it safe, it actually reduces heart disease. So it has a lot of things going for it. So you might be thinking to yourself, well, what's the downside to this? Well, the downside is cost. Any ideas how much it costs?
$200 for one shot.
I'm sorry?
$200 for one shot?
No, that's too expensive. That might be in the US actually. But in Canada, it's $250 a month. Now, if you went to the US and there's a shortage of Ozempic, it's $800 US a month. That's why they're all coming here to get it. Okay, so cost is an important consideration. The other Achilles heel of Ozempic is about 5% of people, they have to stop it because they have profound nausea. And it can also cause gut issues. It can either make you very constipated or it can give you diarrhea. But other than that, it's a very, and then the other big bonus is you will lose weight on it. That's why it's so popular. Now, that being said, the average weight loss is around 9 pounds. So that's not that impressive. But what you're going to find is there's certain people who lose a ton of weight. They'll lose 30, 40 pounds. They're called hyper-responders. So those are the people who really like going on the medication. They do really well. But about half the people who go on it actually don't lose a pound. Okay? And they never emphasize that. Okay? So that's GLPs. Next slide.
What about the thyroid cancer? You want to mention something about that?
Of course. So if you watch your TV ads, they'll always say, if you get a swelling in your neck, ask your doctor. So in clinical toxicology studies, they found that when they gave rats very high concentrations of this drug, there was what was called hyperplasia of cells that make calcitonin. So because of that alone, it never caused cancer. They basically said, okay, that's a possible risk of this drug, is it could possibly cause a rare form of thyroid cancer. Now, there's been literally 20 plus million people on this drug. There's never been a case of thyroid cancer ever been described. Okay, so the problem is, especially in the States, the FDA, once they give you a possible association, you list it. And if you list it, you can't sue them as much. Okay? But I've never seen thyroid issues with the drug. Oh, again, this is fairly complicated, but it just basically tells you a certain number of individuals, they get profound nausea. The cynic would say, well, that's why they lose weight, because they're throwing up all the time. But basically, it's about 5% of people can't do it. Next slide. Okay, and again, I alluded to the GI issues. Next slide, please. There's another medication called DPP-4 inhibitors. These aren't as commonly used nowadays. It's a pill you take. Examples are here, linagliptin, saxagliptin, sitagliptin. Basically, they inhibit the enzyme that normally breaks down your natural GLP. So they're relatively effective. They're modest in their effect. They're no different than placebo. They can never cause hypoglycemia. The only issue is they've never been shown to reduce heart disease, and they're relatively modest in their effect at lowering sugars. So their use has been dramatically decreased now that we have GLPs. Next slide. Again, I just told you that. Next slide, please. Last, I'm going to finish off with SGLT2s. These are the ones that work on the kidney. Basically, they make you pee sugar. And trade names for these are Jardiance, Forxiga, and Invokana. Have you heard about those before? Again, they're on TV. Next slide. So here's your kidney. And basically, in your kidney, there's transporters that regulate the excretion of blood sugar into your urine. And in diabetics, your kidney tends to reabsorb too much sugar. That's part of the pathophysiology. The kidney adapts, retains too much sugar. That's part of the reason why your sugars go up. What these drugs do is they inhibit this enzyme, and they basically make you pee out sugar. So if you pee out sugar, it's going to lower your sugars. Now you can also see what's also going to happen when you pee out glucose. You will lose weight. It will also make you pee out fluid. So people who go on drugs like Jardiance, on average, they'll lose about 6 to 8 pounds as well. And it's very consistent. Almost everybody who goes on it will lose it. Next slide. And that's how they work. Yeah. Who likes animation here? And again, it's very interesting. When you do a dipstick on a diabetic, frequently you'll now see plus 50 glucose in the urine. Now, that used to be a bad sign. But nowadays, I like to see that because it means the patient's actually taking the drug and they're peeing out glucose. So, these have become very important drugs because they're turning out to be one of the most important things you can take to protect the heart and the kidney. This reduces your chances of dying from a heart attack by almost 40%. This reduces your chances of getting end-stage renal disease by almost 90%. These are game changers. Okay? Next slide. And the first trial to really show that was the EMPA-REG trial. Basically, it showed that it reduced heart attack and stroke, but the other thing that was found out for the very first time, it dramatically reduced heart failure. And not only did it reduce events, you lived longer. It reduced cardiovascular death. And as alluded to, it was very good for your kidneys. And once that trial came out, it really increased the use of this class of medication. Next slide. And the reason I put this slide up is the clever ones in the audience will see that the curves separate very quickly. Now, basically that shows when you go on the drug, you get an immediate benefit very quickly. See, most drugs we use to treat heart disease, it takes up to a year before the curves separate. With this class of medication, you get an immediate benefit, and much of that is being driven by reduction in heart failure. Next slide. So, because of that trial and other trials, basically the guidelines have changed. Again, this is too complicated, but next slide will show you the highlights. Basically, when you treat diabetes nowadays, if you have a history of heart disease or renal insufficiency, you really got to consider putting the patient on an SGLT2 or a GLP agonist. You can't just use any old drug. Those people especially benefit from that. Next slide.
How expensive is this one?
Well, SGLT2s, examples like Jardiance, are about $3 a day. And if you have to pay out of pocket, I tell them to cut the pill in half, and you get just as much benefit, so it's $1.50 a day. Forxiga, which is one of those, just went generic this month. So the cost is going to be dramatically decreased that way. Okay? They're pretty cheap to make as well. Okay? So they're really, and it's very interesting, until recently the BC government wouldn't pay for any of them other than Jardiance, and you had to go through all kinds of hoops to do this. Now they recognize that it's a very important drug, and it's easier to put people on it.
But not Ozempic.
You can go on Ozempic.
No, I mean, in this case, it's being paid by
Pharmacare?
by the system, but not.
Well, Ozempic is paid by pharmacare as well.
Just recently.
It has been covered for some time. To get Ozempic covered, you had to be a type 2 diabetic, you had to be tried on metformin, you had to be tried on glycoside. And then once you exhausted all those possibilities, they would then cover it. Then the other issues, people always forget there's a deductible in BC. So even if you only make $30,000 a year, you're expected to cough up the first $1,800. Okay?
For any medication or all medication?
All medication. Okay? But again, generic SGLTs are now available and the cost is really going to come down. Next slide, I hope, is my final one. So, I hope I've impressed to you that diabetes is a common condition. It really affects your risk of getting heart disease or kidney disease. In terms of treating it, there's a big environmental component. So body weight's very important. Diet and exercise is still a very important feature. The problem is no one's ever developed a way to do that consistently. And then I told you about diabetic medications and really emphasize the newer medications like Ozempic and Jardiance show great promise to dramatically reduce heart disease and kidney issues. Now, I've been spending a lot of time talking. I'd be very happy to answer any of your questions. Thank you.
That people, when they get older, quite often suffer from peripheral neuropathy.
Yep.
And how likely is that caused by diabetes?
It's an interesting question. Now, peripheral neuropathy itself is quite common in people without sugar problems. So as soon as you present with numbness in your feet, the first thing your healthcare provider is going to have to do is, one, make sure you're not a diabetic. The other thing, they got to make sure you're not B12 deficient either. So people with B12 deficiency can also, so there's a couple of things you always got to rule out when someone presents with numbness in the feet. But the problem is the vast majority of people with numbness in the feet, it's idiopathic, meaning the doctor's an idiot and can't figure it out. Okay? That's such an old joke. but it just tells you we don't know everything, okay? So.
You didn't mention anything about the hereditary factors as for developing type 2.
Yeah, well, I alluded to that earlier. So it's very interesting. Family history is important when you see a person with diabetes. Because if your mom or dad had diabetes, your chances of getting diabetes is close to 50% in your lifetime. Okay,
My
so.
mother and 2 of her siblings were type 2s.
And, well, your chances are 50%. Okay, don't gain weight as you get older. Okay, so family history is a very important component when you assess someone with diabetes. Like I alluded to, if you're Fijian, like some Fijian families, 85% of them have diabetes. But it's still the environmental component. If you gain weight and you're inactive, that's going to allow that genetic component to express itself. There was another question.
You had said just the last little bit about how if you were going to prescribe Ozempic, first they had to go through metformin and then they had to go through something else. So does that mean that, just theoretically, if this lady here was newly diagnosed with type 2, she would have to be on those less...
Costly.
Yeah.
Yeah, that's purely a function of pharmacare. Okay, you can go on Ozempic right off the bat, but your insurance company won't pay for it. Now, it's very interesting. The insurance companies, I shouldn't be so cynical, but I am, they're not really interested in you living a long time. Okay? So in this province, if you want to get insurance coverage for drugs like Ozempic, you actually have to go through the government first. So I have to make an application to Pharmacare, and I have to make a statement saying, yeah, this person's a diabetic. And until recently, I had to say, yeah, they've been on metformin for 3 months. They've been tried on glyburide for 3 months, and both of those aren't working. Then they would become eligible. Now, about 2 months ago, there was a big headline saying BC has opened up and made it simpler to get Ozempic, which is true. Now, you only need to be on metformin for 3 months, and then if your sugars aren't on track, then you can become eligible for Ozempic. But again, the cynic would say, actually, all other provinces, even Newfoundland, where they don't have enough money to buy books, they were covering Ozempic right off the bat. You didn't need to go through glyburide. So BC finally joined the rest of Canada to do that. Okay? But basically, to give them credit, they now are covering it. And, you know, it's become a very important component of treating diabetes. Okay?
Yeah, I just got recently diagnosed with type 2 diabetes, and they put me on metformin,
Yep.
which I can manage pretty good during the day, but my morning sugars are usually high.
Yep.
Now, they told me to take 2 at nighttime, which doesn't seem to do much.
Yep.
How does metformin work? How long does it stay in the system for, and when is the strongest? Like after you take it, how long does the strength last?
Yep. So, very good questions. I couldn't have planted a better question than you. So metformin mainly works on your liver. Now, when you sleep, you obviously are not eating, okay? And your blood sugar will tend to go down. So when your blood sugar tends to go down, your body puts out signals saying, okay, sugar's going down, I need to raise my blood sugar. Now your liver is a big bag of sugar. And when this happens, when your sugar starts going down, your body will put out a signal saying, okay, sugar's dropping, please release glucose from the liver. Now, in diabetics, their livers release too much sugar while you sleep. So that's where metformin mainly works. It doesn't do anything for, you know, when you eat food and you get big rise in your blood sugar after you eat. Metformin doesn't work that way. It only mainly works on the liver affecting your morning sugars. So that's why they often say, now the issue with metformin is you got to take it with food. If you don't take it with food, you'll get an upset gut. So most people take, I usually prescribe a pill with breakfast and then 2 pills with supper time. But if you wanted to try to lower the morning sugar, what I'll tell people is take the pills with a snack at bedtime. And that way there you'll have a higher drug level while you sleep, and hopefully your morning sugar will get better. That being said, don't focus too much on your morning sugar. It's the A1C that I'm interested in. And as long as your A1C comes in at 7%, you're doing fine. Okay? Does that make sense?
Yeah.
Okay.
Non-diabetic people, so I'm diabetic.
Yep.
And, you know, it goes like this. Do non-diabetic people have those swings? I know their overall A1C is going to be good, but
Yep.
do they have those daily swings as well?
They do. It's very interesting. I'm not a diabetic, but I prescribe those glucose sensors, so I decided to wear one myself. And it was very interesting. I used to have oatmeal for breakfast, and I found that made my sugar go way up. So I stopped taking oatmeal. My sugar's good. Now, there was other foods that would make my sugars go down. Any idea what makes your sugars go down?
Prunes?
I'm sorry?
Prunes?
No, that would make your sugar go up. But it's very interesting. When I would have a steak with a glass of wine.
Red wine. I was going to say red wine.
You know, in certain people, alcohol can really make your sugars go down.
Yeah.
And I always remember I had a diabetic. His name was Clifford. He was a commercial fisherman. And he used to call me and say, gee, Dr. Bondy, the only way I can get my sugars down is Crown Royal. And I'm drinking 4 shots with each meal. And I said, Clifford, that's not a good way to lower your sugars. But it's very interesting. In some people, certain foods, certainly alcohol, can make your sugars go down. And it's very interesting in young women, their morning sugars, it's perfectly normal for their morning sugar to be 3.5. And of course, as a diabetic, they always warn you, oh, your sugar's under 4, you're hypoglycemic. But your sugars do fluctuate. Okay?
But they don't reach 31.
They don't. You're absolutely correct. Actually, most type 2 diabetics, they don't go that high.
And I did.
Do you?
Yeah,
Okay, you're insulin deficient. You need a little bit of insulin.
Is that, because that is my, I'm right now trying the metformin, and like I said, I can manage it during the day, but not in the
Yeah, you may need a little bit of insulin. The other thing is, you know those ones, the SGLT2s that make you pee out sugar?
Yeah.
They work really well in people like you because if your sugars go high, you just pee it out.
Well, I have an appointment with the specialist in July. So,
Okay.
But that's why I'm glad that I got some questions for them.
There's a lot of good options for you.
Yeah.
So, sorry.
You use the term appropriate level of A1C. What is the appropriate level?
Again, for most people, it's 7%.
Or less?
If you can safely accomplish that. So if you can normalize your A1C, that's great. But I wouldn't add insulin to your regime and risk hypoglycemia to do so. And
I'm not a diabetic.
I know, but A1C is 7%, you get most of your bang for your buck. It really dramatically reduces your chances of heart disease. And if your A1C is 7%, your eyes will be happy and your kidneys will be happy. Because if you get your A1C below 8%, you virtually eliminate microvascular disease. Okay? But A1C is your target for most adults. But if you're like 90 years old, 8.5 is probably fine. Okay? You have to individualize. You can't make firm goals like that.
No, it's when your best before day, right?
What's that? Yes. Well, you'd be surprised. I have people who have diabetes who are in their 90s and they're doing incredibly well.
I just upped my Jardiance upped in milligrams. I think it's 20 milligrams now.
It's 25 and 10.
Okay, it's 25 now is what I'm taking.
Yeah.
And I've noticed that I'm peeing a lot more.
Yeah, no, that's the downside. And it's very interesting. From protecting the heart and the kidney, there's no difference between 10 or 25. So most people I use 10. The only people I go to 25 are in people whose sugars are high and I want them to get their sugars down.
My A1C's where it's like 7.1 to 7.6 for the last couple of years.
Yep.
So that's why she gave me that to see that I'm down more. I have no blood now.
If you're peeing every hour, I'd go back to the 10. It's not worth it.
Well, we'll see what happens next blood work, right?
Yeah, we'll see what happens.
Yeah.
You've been talking for an hour and he hasn't peed yet.
That's right.
She actually had a question.
Oh, how are we doing for time? Are we getting?
Oh, it's about 3:15.
Oh, okay, so I guess we'll.
Well, I'm actually not going anywhere. So.
We just.
Just a quick question about, with respect to insulin resistance.
Yep.
What's your view on, in addition to measuring fasting blood sugar, but measuring fasting insulin?
Yeah, a lot of physicians measure fasting insulin. I know almost with 100% accuracy who's insulin resistant. You just got to measure the waist. Okay? The other issue is when you look at fasting insulin levels, if you look at the reference interval, it's anywhere from 250 to 1200. The normal range is too wide. So its predictive value is very limited. Usually when you measure something, you have to have a reason to measure it if you're going to change things. And the vast majority of people with diabetes who have central obesity, their insulin levels are going to be high. Okay? Now it's very interesting. How many hormones do you make that lower your blood sugar? And how many hormones do you make that raise your blood sugar? Well, there's only one hormone that lowers sugar, is insulin. But it's very interesting. Nature has provided, see, blood sugar is so important. You have multiple hormones that will raise your sugar. So adrenaline will, cortisol will, growth hormone will. So obviously nature said, I'm going to really defend against any possibility of getting a, if you need glucose, you're going to have hormones that'll do it. But for some strange reason, it only decided to make a hormone, insulin, to lower it. So that's why you get diabetes, because if you don't have insulin, that's what happens.
You say that type 2 diabetes is very dangerous. It often has no symptoms. So when and how often should you be tested for it?
Yeah, it's an interesting question. I hope I didn't say it was very dangerous. It does increase your risk of heart disease, okay?
Potentially.
And so basically it depends on your age. If you're 30 years old, you don't need a fasting glucose. And that's our main screening tool. But once you hit the age of 40, certainly if it's a male over 50 and a woman over 60, you really should have an annual glucose level, okay? And again, like, there's no symptoms to diabetes. So you really got to pick it up on a biochemical. That's one of the reasons why you really should have a family doctor, and you do get followed.
How do you get one?
It's a $1 million question.
So why not measure A1C as a screening tool?
You can. I actually prefer that. We never used to recommend that, mainly because of costs.
Yeah.
A1Cs cost a lot more money, but I personally always order an A1C on every person that I see, even if they're not a diabetic.
Then you don't have to have fasting.
You don't have to be fasting, and the other issue is A1C is a much better predictor of your risk for heart disease. Okay? So if your A1C is elevated, there's a linear relationship between your risk of heart disease. So A1C has, and actually in a lot of cases now, it's actually really, has anybody had lab work recently? It's really hard to book an appointment for a fasting level. So that's why we encourage people to go for non-fasting specimens, even for cholesterol. And the A1C gets around that as well. You don't have to be...
Get that. You can ask your doctor to have an A1C.
You can get an A1C and a non-fasting lipid profile. There's very few tests that actually require fasting. The only reason I often ask for fasting, because I treat a lot of people with high triglycerides. Triglycerides really are best assessed in a fasting state.
Why are women older at becoming brisk than men?
I'm not quite sure if I understand your question.
Well, you were just talking earlier and you said men at...
That's mainly driven by heart disease, that recommendation. So when they recommend your cholesterol measurements, see, women always live longer than men. Okay, on average, it's up to almost 5 or 6 years now. So the age of 50 and 60 is just basically, once you reach those ages, your risk of getting heart disease goes up dramatically. Now, there are exceptions to that rule. If you come from a family history of diabetics, you obviously should get your sugars measured earlier. So in some people, if everybody starts getting diabetes at 40, you should really start getting your sugars measured at 40 or even earlier.
All right.
Good.
Well, wow. I think I'm a little depressed, actually. Sorry. It was really good information, but I find I get overwhelmed from time to time because, as a diabetic, you try so hard, the medication, the diet, the exercise, and sometimes it's hard to stay motivated and do it all.
Yeah.
So, but it's always good to hear, the pathology of it.
Well, that's why I like working at a diabetes center, because there I have a variety of healthcare people there. I got dietitians, I got nurses. And you're right, you have to have continual monitoring, but also encouragement. Okay, and that's one of the issues with diabetes. It's something that it's going to be there for decades. And basically, what I see where people run into trouble is when they stop coming, they get discouraged, and then they don't even know where they're at. They don't get lab work, and they come in, and then that's where the disasters happen. But I want to be more encouraging, because like I alluded to, the newer medications are so much safer and so much better for your heart and your kidneys. Okay?
Well, thank you so much for all that
You're welcome.
information. We really
Thank you.